All right, thank you everyone. My name is Cal Gunasingha. I'm a general surgery resident at Walter Reed. I am presenting in lieu of Dr. Patrick Benoit, who's one of my co-residents and co-researchers on this project. So our project is entitled Just Read the Sign, and this is how we've improved our protocol adherence to antibiotics and imaging in appendicitis through just simple signage and re-education. I have nothing to disclose. So appendicitis is one of the most common general surgery or emergency general surgery procedures that happen. It's low morbidity, but associated with a high cost, and usually that is due to length of stay as well as diagnostic imaging. Our trauma acute care surgery service has a protocol in place, and this is available to residents as well as other teams in the hospital to view. And it was implemented in 2016. The protocol overall is for generally young to middle age adults, and it's for uncomplicated appendicitis. Really, it just says you diagnose this using a CT scan of your abdomen and pelvis with IV contrast, and to prescribe cefoxitin prior to the OR. Once they go to the OR, they're discharged within 24 hours, and with a standard set of medications and no continued antibiotics. The problem was when we did an internal review of protocol adherence, we found that not only the emergency department but also our own residents weren't really adhering to this protocol. So what we did was initially re-educate the residents on this is what's needed, and go through like a didactic session on the types of imaging that's indicated for appendicitis as well as the antibiotics that are needed. And then we also put up simple signage in the emergency department for the providers there, as well as on the on-call radiology room, stating the antibiotics that are appropriate for uncomplicated appendicitis, as well as the type of imaging that is also indicated. And we thought that just by having the simple sign that's easy to access for these providers, they would follow these instructions, and that's what we looked at. So what we found that once we talked to the surgical residents about having cefoxitin as the appropriate antibiotics for these patients, our adherence increased, right? So only 47% of patients were, and prior to this, 47% of patients were getting Zosyn, which is not necessary for uncomplicated appendicitis in a relatively healthy patient. And then after that, you can see as much as 90% of patients were getting the correct antibiotics. With the emergency department, same thing. We found that instead of asking the residents what they wanted, and then our residents putting the orders in, the emergency department was automatically putting in the cefoxitin for those patients, or asking us, hey, we ordered this already, is this good to go? So we saw that, and that to us, that meant that the patients were getting those antibiotics sooner prior to us getting consulted. Same thing with the CT scans. We found that prior to our interventions, patients were getting non-con CTs as well as CT scans with IV and PO contrast. Once the simple sign was placed, 75% of the appendectomies were getting CT with IV contrast only. Prior to that, you can see, it was as low as 6% and then mostly in the 40s. So as I said, overall, just by this simple sign, as well as the re-education, we were able to increase adherence to our protocol that was published by the General Surgery Department. And we think that this is due to just the fact that it was easy to access versus having it on an app somewhere within another spot, and everyone would have to find it and refer to it. We found that again, the radiology interventions also helped decrease unnecessary, PO contrast, plus the wait time for that PO contrast to reach, where the appendix would be before the patients getting the scan. And both of these interventions that we did were really just printing having a re-education session with the residents and then printing a sign and posting it, both of which are really cost-effective and timely. So this is a team that we worked with. Again, my co-resident and co-researcher, Dr. Benoit, is the primary researcher, and the rest of the team is here. Thank you. Any questions?
Hi, I'm Joe from Woodland. A great study. I just wanted to ask, just like anything else, whenever you get emphasis, then all of a sudden sometimes goes out the window. So you're doing a study, you're telling the residents we're doing a study, you're telling them in the ER we're doing a study, compliance goes out. What's to say 5 years from now, you're right back to where you were?
All right, thank you for your question. So your first question was in reference to compliance and just the continued reminders. So I think, as you said, right, like right when you do the intervention, people follow through, right? And they're like, oh yeah, we just heard about this, we should do this intervention. I think with the signs, the nice thing is it is present always. And then the same thing with the residents, like, you know, from junior residents, like, you know, senior residents to junior residents, that transition of information is also important. But again, as the years go on, we have to make sure that we continually monitor the interventions that we do and make sure that they're continuing to be followed, because there's always the risk that, you know, that drops off, or, you know, you get a new set of residents that haven't received that information, or someone just takes the signs down that we've posted. And for your second question, and due to antibiotic choice, so again, these are just a dose of preoperative antibiotics for appendicitis. We follow the IDSA guidelines, and again, those guidelines, you know, they're guidelines, and a lot of the preoperative antibiotics should be based on your hospital's antibiotogram. And then the biggest emphasis that we have is like there's no post-operative antibiotics, especially if that patient doesn't need it. Now, if you're in the operating room, you see a perforation at that time, that is, you know, clinical judgment. And the same thing with preoperative antibiotics. If you have a patient, and just to note, in our study would not include patients that were higher risk or had more significant comorbidities. So if those patients would require like a dose of preoperative Zosyn, more than appropriate for them to have it. All right, thank you.
And then to piggyback on that same question, so, you know, we talk about process improvement. You know, strong interventions are ones that typically cause forcing function. So you kind of mentioned some of these limitations, but do you have any ideas of how you could apply this in more of a, you know, sort of strong intervention, forcing function to improve standardization?
Yes, just to clarify your question, Dr. Holt. So basically you're asking, you know, how do we keep doing these things where you don't have to like recheck yourself?
Correct. So anytime you're doing a kind of educational intervention, it's like you mentioned, there's the risk of the sign coming down, the risk of the next person who's in the ER doesn't know to look for the sign. You know, educational processes, while helpful, are not the strongest. You know, things like, you know, automatic, you know, stops in your EMR to check for medications. Do you see any application where you could help to standardize this process?
Yeah, so I think, you know, some things are going to be based on your EMR limitations. So just currently, right now, I think things like this, where you have your antibiotic choice. Right now, I'm using Epic at an outside hospital, right? So those things do pop up when you're ordering, you know, like meropenem. They say, oh, you have to get an ID consult, or like, what's the reason? And they ask that. So I think if your EMR is possible, it has a possibility of having those, like, you know, very targeted alerts. It's very possible to incorporate your protocols into that. And I do think, like, maybe when new batches of residents come onto rotations, like some of our services I know have like a, you know, booklet of like, this is what to do. And I did a different project where we look at like opioid prescriptions, and we found that like the interns were very consistent in providing those correct amounts that we had prescribed, versus, you know, the more senior residents had already developed the ways of what they were prescribing. So it was like more convincing them versus the new batch of residents coming in.
All right, great. Thank you. Do you have any other questions?
Awesome. Thank you.
Thank you. All right. So our next presenter is going to be Lieutenant Ashley Hafer, who I believe is at Portsmouth, but working with colleagues at Walter Reed, will be presenting Urologic Care Afloat Navy Provider Education, Development of Urologic Emergency Simulation Curriculum Models.
Good morning, everybody. Yes, so I'm Lieutenant Ashley Hafer. It's a pleasure to be here with you this morning. As we said, we're going to talk about development of urologic emergency simulation models today for a curriculum, UCAN-P, which when I submitted this abstract stood for Urologic Care Afloat Navy Provider Education. How do I advance? Sorry. Can I have the next slide, please? There we go. But we changed the name, and it now stands for, next slide. Urologic Care Army, Air Force, Navy provider education. So one team, one fight. Am I right? Okay. All right, so this is my disclosure slide. It's a standard military disclosure. Additionally, I have no financial relationships to disclose. And last, do we have any children in the audience today? No. Okay, great. This presentation is rated at least PG-13, so everyone prepare yourselves for that. So to give you a little bit of background, urologic procedures are commonly performed at sea by general surgeons, but there are no required procedure minimums for urology procedures in general surgery residency training. Additionally, urologists are not included in our fleet and field surgical teams. This means that care for patients with urologic emergencies often falls to the general surgeon present or is otherwise delayed until the patient can be transferred to a higher level of care. This highlights a gap between training and practice expectations for our military general surgeons. So UCAN-P was developed to provide military general surgeons with needed training to diagnose and treat frequently encountered urologic emergencies in order to improve a general surgeon's ability to address these problems in austere environments without a urologist present. To better gauge how to bridge this training gap, we conducted a needs assessment to identify the diagnoses and procedures to include in the curriculum. And as you can see on the slide, we identified a bunch of diagnoses and procedures. And so because this was a simulation curriculum, we needed simulation models for these procedures. So we needed to have a bladder and abdominal wall model, a phimosis model, paraphimosis model, and a complete scrotum model. So we created prototypes for each of these models. We wanted each model to be cost-effective, easy to assemble, satisfactory quality for learning, and we define that as simulating human anatomy, but also being adequate for performing the procedures. And we determined the adequacy of each model through prototype testing. So 5 urologists from Walter Reed and Fort Belvoir participated in our prototype testing. We provided them with the models, and we asked them to perform the indicated procedures. When they completed the procedures, we asked them to complete a survey on how similar the models were to actual tissue, and then also how similar the procedures were to perform and how much they resembled real life. Their responses were on a scale of 1 to 5, with 1 being very dissimilar and 5 being very similar. We also solicited for general comments and feedback. So we'll start with the bladder and abdominal wall model. Here we have a snap top plastic box that I cut a hole in. That represents the pelvis, a balloon filled with water, a little bit of tape on top. That's our bladder. This is a household sponge cut in half with some transport tape representing fascia. And then this is everything kind of put together. This was adapted from a percutaneous SP tube model that was previously available in the simulation literature. So the urologist gave this a 3.7 for its similarity to actual tissue and a 3.8 for its real-life procedure performance score. But their main critique was that we needed to make the bladder wall thicker. So we did that by adding 3 layers of Coban to the bladder. So this is a picture of our final model. As you can see, we also added some skin for the final model prototype to make it even more lifelike. And we have a final cost for this model of $2.05, which if anyone's familiar with simulation models, you know they can be extremely expensive. So we thought this was very affordable, but I can do better, just wait. So next we have the phimosis model, which you can see our prototype is a Penrose drain, which we cut a slit in and then secured it with silk tape, very inexpensive. So they give this a 3.4 for similarity to actual tissue and a 3.6 for real-life procedure performance. But a couple comments. Number 1, they said, the foreskin needs to cover the meatus. Okay, that's fair, kind of the definition of a phimosis. And then also they said, again, we need some thicker tissue. So again, we added some Coban. We were able to cover the meatus and make the tissue thicker so they had something to sew to. Final cost of this model was 22 cents, so very affordable. Next, we have our paraphimosis model, which is featured here on a banana. It's also a Penrose strain. There is a gummy lifesaver in there, promise, and then 1 polyband, which is just a small rubber band. So they gave this also a 3.4 for its similarity to actual tissue and a 3.6 for procedure performance. Their main comment was that it was sticky, but I think that came from, so urologists are trained when they encounter a paraphimosis to immediately apply manual compression and try to reduce it through non-surgical means. However, doing this on our model led to a little bit of melting of the gummy lifesaver, and it made everything very sticky. So after our first couple urologists went through, we had to tell them, please refrain from your urge to manually compress this paraphimosis, and it won't be as sticky. So we didn't make any changes to the final model, and this is what we came up with for the course. Final cost was 23 cents, probably a little extra because we had to put candy in there. All right, so the last model is our most complicated. It's the complete scrotum model that we use for scrotal exploration, orchiopexy, and orchiectomy skills. So going from left to right, we have the olives, which represented the testicles. The green olive is the non-torsed viable testicle. The black olive is the torsed non-viable testicle. And then yarn, which we use for our cord structures, the blue being the veins, the red being the artery, and then the gray representing the vas deferens. Those were all placed into little finger cots representing the tunica vaginalis. Those were then placed into stockinette, which represented the cremasterix, and then all placed into a household rubber glove, which represented the dartos fascia. So as you can see, lowest scores overall for this model for everything. So they said, oh, the dartos layer is too thin. Okay. They said the olives smell. Fair. They said they couldn't tell what was supposed to be the vas deferens when they felt the cord structures. They complained the model didn't bleed. I don't know if I can fix that. And then they said these testicles are like baby testicles, which was also very fair. And when I read that comment, all I could think about was Zoolander. What is this? A model for ants. Anyway, so we made some changes. We replaced the yarn with a rubber band to represent the vas deferens, so very easy to tell it from the other vasculature and the cord structures. We abandoned the olives and we replaced them with silicone testicle models that we made using a chocolate egg mold. We then replaced the finger cots with latex balloons. We replaced the stockinette with Webril under cast padding to represent the cremasterix. And then we lined the inside of the glove with silk tape to make it a little thicker to sew to. Final cost was $11.11. By far our most expensive model, but still relatively inexpensive when you think about simulation. So our takeaways. Simulation development is an iterative process. It takes a lot of trial and error. Try to use what you already have or expired items to keep your costs down since it can be very expensive. Mass reproduction is very time consuming, so you don't want to make your models too complicated. Coban is a very versatile product, and you want to avoid perishable foods when you're making models. So this is a picture of my daughter who was helping me put together 30 bladder models for a course we did back in March. She was about as helpful as you would expect a 3-year-old to be. And with that, I would love to take your questions.